Good afternoon, and thank you for joining us for this IDA webinar, The Opioid Epidemic, Is There a Solution for Your City? Before we begin, I would like to go over some instructions on how to participate. You'll notice on your screen, the viewer window is to the left and the control panel is on the right. The orange arrow allows you to open and close the control panel as you wish. You can switch to full screen and you can hide the panel as well. Right now, all attendees are in listen-only mode and have been muted. In the audio pane, you'll notice you were defaulted to mic and speakers when you signed into the webinar. If you would like to use the telephone, simply click here and then dial in with the provided number. You'll be asked for an audio pin, which will come up below the number. In the questions pane, you can type in questions when you have them, and you have the ability to raise your hand. This webinar is being recorded, and a link to the recording will be sent around afterwards. We will also address all questions and answers towards the end of today's presentation. Finally, if there is anyone who is watching this webinar with a group, please write into the questions pane and let us know how many people are joining you today. With that, I would like to introduce Laura Coons, who will be moderating today's webinar, and Captain Houston Park. Since 2009, Laura has worked in community outreach roles, representing several of the nation's most respected addiction treatment providers. Currently, Laura is the Regional Outreach Director at Futures of Palm Beach, a private addiction treatment facility in Jupiter, Florida. She is also the founder of 3 behavioral health care resource networking groups, including one that is online with over 300 active members nationally. And Captain Houston Park is assigned to the Emergency Medical Services Division of the Palm Beach County Fire Rescue Team. He has spent the last 26 years serving the citizens and visitors of Palm Beach County, Florida. Thank you so much, Laura and Houston, for being able to join us today. Laura, you can begin whenever you're ready.
Okay. Thank you, Rebecca. Hello, everyone. First of all, I want to thank IDA for this opportunity, and I want to thank everyone for being on the call today. Hopefully, as you learn about this important information, you will take something of value away. Before I turn it over to Houston, I want to go into his credentials a little bit. He is currently a captain with the Palm Beach County Fire and Rescue Department. He has been for almost 28 years. He is a career paramedic and currently oversees around 1,500 paramedics and firefighters within Palm Beach County. He has a specialized background in hazardous materials and toxicology, which made him a very appealing candidate to chair our Palm Beach County Heroin Task Force and focus on the epidemic that we are faced with in South Florida. About a year and a half ago, he began developing the suboxone pilot program in conjunction with JFK Hospital and the University of Miami. And that is what you all will be learning more about today. So without further ado, I give you Houston.
Hello and good afternoon. Thanks for the opportunity to speak to everybody, and thank you to Futures for putting this together. There's a lot to be said about this epidemic that is challenging our country. I'm going to speak on what we're seeing here in South Florida, particularly within the Palm Beach County area. Most of the statistics that I'll provide have been validated or backed up through data research and through the medical examiner's office as far as our numbers when I get into a little bit of data. In the year 2016, Palm Beach County was seeing this epidemic surge rapidly increasing, and we had documented 596 deaths associated to opioid or opiates, particularly that with heroin fentanyl, and in some cases, some carfentanil was also detected. That's a very large number. It's very concerning. As a paramedic, I was seeing that we were being challenged by this continuous revolving door of receiving patients in the field who had overdosed, providing a typical pre-hospital dose of Narcan or naloxone, and in some cases, treating the same individuals 4 times in one day. And so I wanted to look at this a little bit differently. I started to do a little bit of research and determined that over that period of time of 1 year, when I was looking at the amount of deaths that occurred, there were over 4,000 generated EMS emergency calls for service as a result of what we refer to as an ingestion, which we have further defined as an ingestion by overdose to an opiate. And we were able to re-evaluate our data gathering techniques and use keywords such as Narcan, whether they had a response to it or not. And then if they were unfortunate and they were to pass away, we were able to confirm the backup medical examiner records to determine the cause of death. 4,000 EMS generated calls in this community is a lot of emergency response resources. That's taking up a lot of time throughout the county. Palm Beach County is the second largest county east of the Mississippi, and right now has a population of about 1.5 million, particularly during the winter. When you see that level of emergency response, it's not a proud figure that we have, but it's a realistic number. It's a number associated in the state of Florida as the leading county for opioid overdoses. There's a few other counties that are just right behind, to include over on the west coast of Florida as well. But unfortunately, during that period of time, we had the highest number. There's a couple reasons for that. There's a lot of discussion and groups that have been developed as a result of this. In particular, one of them is that for whatever reason, South Florida has become known as one of the rehab capitals of the world. And so we have a bunch of very good, well-intended providers. And then we have a couple of, I won't even say a couple, I'll say a significant amount of unscrupulous providers that are just trying to prey on this addiction. So I have a tendency to kind of get a little passionate about this because it is my goal to try to prevent the ongoing revolving door of the opiate abuse. And so through research, we were able to come up with a new program that significantly has reduced the opioid overdose, and especially for those that repeat.
Okay.
So what we needed to do was, I wanted to look at this, and I have a tendency to look outside the box or work outside the box. Like I said, we were treating the patients as was any other agency in the country that's dealing with pre-hospital overdose issues. And so one thing that I like to bring up is that the longer I've practiced as a paramedic, which is now going on 31 years, I realized that you become either hardened and intolerable of people, or you become compassionate. And with the compassion comes the ability to provide care. And you may or may not be liberal, you may be conservative, it really doesn't matter. But what I found is I became very liberal in some of my thoughts, and those thoughts were that of helping people with an addiction. So when I started looking at this, I was driving to work one morning, and there was a program on NPR radio, and they were specifically talking about areas in the Northeast, in Maryland, and also areas in Michigan where there were significant overdoses as a result of heroin or opioids. And they talked about a standalone suboxone program. And so these were patients that willingly, on their own, went to a standalone facility to receive suboxone, and then to get on the road or pathway to no dependency or sobriety. As I looked into that, I found out that Yale University had done a study, particularly with the results of suboxone with behavioral health counseling. And I found that very intriguing and read it in great detail, shared it with some medical directors that I work with. And we were able to determine that the study showed it at one point the patients were showing a 90% success rate of not returning to the use of the opioids and staying clean. That's an unheard of number. And I felt that that was probably one of the best ways that we might look at this. So I approached our medical director for fire rescue and I asked if we could do this program. And the goal would be that we would be notified by the emergency rooms when we had an opioid overdose. Typically, we were bringing them in, or one of the municipality fire agencies was bringing in these patients to the emergency room. And what we would do is, if the patient was willing, and the hospital would then reach out to us, one of my team members, and the most important critical part I think that has brought success to this program is we went to visit the patients with a peer group counselor. And these peer group counselors do amazing work. The reality is that when you walk into an emergency room, the patients don't trust anybody of authority, anybody wearing a badge, or anybody that potentially could be perceived as going to put them in jail. So we found that they didn't want to talk to us. But when we brought the peer group counselors in who are in recovery, and we had very specific requirements for those that went into the emergency room with us, they had to be certified as a peer group counselor, which is a 40-hour class. They had to have 500 hours of patient contact, and they also had to live a life of sobriety for 2 years going into this program.
Houston, can I just interrupt you for a moment? Can you just touch on, before we continue into the program, on what happens to an individual when they are some living on the streets? A lot are living on the streets in the communities and in the downtowns that a lot of the members are invested in. And what happens to that person that refuses care? They go back to the streets. The cycle repeats. So what Houston is touching on now is that they have found a way to basically intercept that cycle that a lot of these folks have been repeating. Sometimes it ends up in chronic homelessness. Sometimes it ends up in death. And with intervention in a program like this, it ends up with a much different result. So back to you.
Well, the biggest challenge is that we were overwhelming the emergency services in particular areas and the emergency rooms. And so when you look at the typical patient that was coming into the emergency room who has just been reversed from an opioid overdose and now is put into a state of acute withdrawal, they're not happy. They're very uncomfortable. It's a lot of pain associated with it. And in their mind, the only thing that seems to work is to go back out and get another fix or another hit of whatever gave them that sensation of feeling good or being able to forget everything. And frequently what was happening was within the hospitals, these patients were being released within 2 to 4 hours, only to go right back out. And the more that the addiction drove them, the less likely they were to be productive in society. On top of that, there were so many other contributing factors. As a result of that lifestyle, they become much more receptive or possible to have an infectious disease such as hepatitis C. And one of the studies I read through SAMHSA, there was 2/3 of the population that agreed to get tested for hepatitis C after a heroin overdose were positive for hep C. And so not only were we looking at this as a ongoing medical issue and a behavioral issue, but now it becomes an infectious disease issue, not to mention the other infectious diseases that can go with it. So we had a big challenge, and that challenge was to get the hospitals on board. And then actually the biggest challenge we had was at the street level, patients were not going to receive this program. But with the help of the peer group counselors, after about 2 to 3 weeks of finally getting a few successful patients to join our program at no cost, and I'll explain that briefly in a minute, we had people knock on the door wanting assistance. And so the street level language changed the behavior to where everybody was afraid of it to now where they were receptive to getting the treatment. We did a lot. We worked with the hospital at JFK, and through assistance of the University of Miami, we developed a protocol. We worked with a psychiatrist that was initially evaluating these patients that were deemed to be appropriate for the program. And that appropriateness basically was an inclusion-exclusion criteria, as are they in end-stage liver failure that would prevent them, if they were using methadone, that would prevent them from being available to receive suboxone. And then there was a few other things. For example, a patient that was pregnant, we can't give suboxone. That's very detrimental to the unborn child. However, we did come up with avenues for assisted treatment there through Subutex and some of the specific facilities within our community that are designated to help with the indigent care and those mothers that are addicted to opiates. When we would get these patients into the hospital and we would come and meet with them, what we would do is, under the direction of the psychiatrist, they would be evaluated and they would be given their first dose of suboxone. This right here is already saving lives, because typically these patients are discharged within 2 to 4 hours, and now they're being held for up to 8 hours, and in some cases 12 hours, and that alone prevented them from going back out and reusing. When the doctor would give them their first dose of suboxone, we would then come in and meet with them and discuss where we were going to meet them on a daily basis for the next week, every single day. And what we did is we would come in and ask a patient, okay, we're going to follow up. We're going to come see you tomorrow, and we will provide you with additional suboxone. We would do a clinical opiate withdrawal scale to see where they were as far as withdrawal levels. We had a sliding scale and a protocol with medical direction to give suboxone pre-hospital. That's the first time that's ever been done. And one thing that was really important was that if we told these patients that we were going to meet them at 7:30 in the morning, we had to be there at 7:30 because they were fully expecting it, and we had to maintain that level of trust. And so it was really remarkable to actually do this, because they were still non-trusting for the first 2 to 3 days. And then after that, it was almost like they became friends. And I just want to touch back a little bit of what I said about being more compassionate. In this community, what I found was I was a stone figure as far as EMS goes, and I did my protocols and I took care of my patients, and we kind of left the emotional component out of it. But by the third or fourth day, we were giving hugs to our patients, and every single one of them wanted a hug. And so I kind of got the reputation among the crews when they would see me in the emergency room as, oh, there comes the crazy captain that hugs all of the heroin patients. But it actually works. And so the combination there, and the key that I would like to add to that is that it's all about compassion, non-judgment, caring for the patients, and being involved. And we all can form our own judgments on how people got to where they were, but when you really get deep into this, you can see that there is no socioeconomical background that causes them to get there. We've had every walk of life come into this program.
And I want to add something in there. You know, I think a lot of communities, as we highlighted in our statistics down here in Palm Beach County, the issue has grown too large to ignore. You know, so you can no longer really afford to ignore and judge. But then the question is, so that, you know, then now what? You know, what's the solution? You know, which is obviously what we're discussing today.
I just want to add one other thing to that that's really important. Not everybody met the criteria or was willing to be part of the suboxone pilot. And we didn't cast them away. We still provided them with the peer group counseling. We were able to mainstream them into sometimes scholarship treatment facilities, whether it be inpatient or outpatient care, which was really remarkable when you have patients that have lost all hope. Their family has been destroyed, possibly no longer in contact, and now they're needing treatment or care and they can't afford it or they don't have insurance. it was difficult. So we had scholarship beds made available for inpatient care. And then through Palm Beach County, there's also the Drug Abuse Foundation, who was willing and receptive to us sending patients to them for further evaluation and direction into an appropriate treatment program. So let me get into the next part.
Okay.
So just to kind of recap what we did is that we would get these patients, they would show up in the hospital, we would follow up with a counselor, and for 8 days straight, we would treat them with suboxone and brief peer group counseling. I had to budget the time because we would run during this pilot probably 7 to 10 patients a day throughout the county. We drove everywhere. One of the criteria was that they had to have a house. Well, not everybody in this world of addiction has a house. And so I became very creative with that. If they could meet us at a fast food restaurant, that became their house, and I would identify it that way. If they were living in a vehicle, under the state law, a vehicle is an extension of your home, so therefore that vehicle is their home, and we would treat them in their vehicle wherever we could find them. So we would treat them, and we would move on to the next patient. And we started seeing rapid success immediately. The goal was 30 patients as a pilot study, and I wanted to try to mimic or reproduce the same statistical results as Yale. Our goal would be at the end of 7 days is we would do what was like a warm handoff or a soft transition to the healthcare district of Palm Beach County. The healthcare district was established as basically trauma management and care for the indigent. But when I approached them with this, it fit in perfectly. So we would hand them off, and I want to add we had more than what I've mentioned as far as players to help. The Department of Health, the Florida Department of Health, they stepped up to the plate, but they really kind of focus on infectious disease. So the 2/3 of the population that had Hep C was the perfect roadway for the Department of Health to be involved. Not only did they get involved, but they contributed a $60,000 grant, which allowed us to treat our patients that had Hep C with appropriate medications and provide an environment of no more hepatitis C for those patients. So right there, we were already ahead. The healthcare district is a federally qualified health center. And so they're able to get medications at pennies to the dollars of most other facilities. And so we were able to tap into that as a financial resource to provide the cost of the suboxone once they left the fire rescue care. And they would also then start to treat them for other comorbidities. So, just amazing stories. We had one patient that had cervical cancer. I'm not going to go too far into it. I'm going to respect everybody's HIPAA rights, but she had never been treated for it. And now we were treating her for her addiction. She was being cared for her infectious disease, and she was being treated for other conditions that were underlying, and her life was turned around. So those are the type of stories we saw. Once the healthcare district would pick them up, they would continue with the same program. Next week will be 1 year that we've run this program. And our goals were to, first of all, evaluate the first week and compare it to the Yale studies, which showed 90% success rate. And unfortunately, we did not hit the 90% success rate on the first week. We hit 97%. And the reason that we didn't get 100% was 3 of the patients that we enrolled into the program were unable to be found in the 7 days immediately after being discharged from the hospital. So we couldn't even really count them as a statistic, but we're going to stay true to the numbers. So at 7 days, we were 97% success. At 30 days, we came back and reevaluated. And at the 30-day mark, we were at about 76%. Still a remarkable number. That became our challenge. Some of our clients or patients would slide off the slope every once in a while, and we would go back and reel them back in and get them on the path to sobriety and a productive life. So as I said, next week will be 1 year, and our statistical data right now is showing that we're between 52 and 56% success rate of the pilot. Another interesting thing that occurred as a result of this, and there is so much work that has gone into it, is we started looking at other populations, and typically this population has a high propensity to having an arrest record or falling in jail, and then we couldn't treat them. So I got the local sheriff's office and the jail to agree, if it were one of our patients in the pilot, to continue with the program so that they wouldn't have to ride out the withdrawal on a concrete slab. Took it a little bit further than that, and we have a drug court. Most cities and counties in the country have drug court, and the goal there is to keep people out of jail that are addicted, but also to get them off of the drugs or the dependencies. And so the main judge of the drug court enlisted our help, and we started taking in her patients as well, who statistically are about the same across the country, which is 50% success rate. We're at 99% success rate for drug court patients staying off of the opioids. So we've demonstrated that this works, and I really have to add, the most important thing that I've seen is everybody coming together. I like to say that we leave our egos out at the door and we all come in and we work with a common cause. We formed the Heroin Task Force, which initially was 6 people, and we meet once a month, and now it's well over 100 people in attendance from treatment facilities, hospitals, law enforcement, federal agencies. Basically, if there's an agency out there that has potential to be involved with some type of response for an opioid overdose, they're attending these meetings, and they're all networking, and we're coming up with other strategies to helping reduce this common problem. Laura had mentioned that I have a hazmat toxicology background, and my outside of the box thinking would just simply be this: if I were dealing with a pesticide overdose, I would look up to find out if we had an antidote for it, and that's the way we would treat that pesticide overdose. So when I started looking at opioids, we have the antidote. It's Narcan. Narcan saves lives, but it doesn't fix lives. So the additional resources out there, whether it be through medical assisted treatment to include suboxone or Vivitrol or methadone, whatever the medication is, we found that not every patient can fit in one menu. So we want to be able to offer multiple avenues of medical assisted treatment. And by far the most important component that goes with that we found is that peer group counseling and the behavioral health issue being addressed together and with priority. Anybody that became part of this program through our fire rescue agency, I had to overcome a couple things. They needed to make sure that they could touch back with the component of compassion. They have no judgment or non-judgment, caring for the patient, and show respect. And just those 4 qualities, our patients said, made the difference sometimes of them using or not using. And so what we needed to build on from there would be also that of support from the hospitals. I've had the hospitals locally change some of their protocols so that, for example, Good Sam Hospital in West Palm Beach, if a patient is being discharged as a result of an opioid overdose and now they're ready to leave, they're left with or discharged with information on overdoses and a prescription for Narcan and a physical dose of Narcan as they leave. We did the Suboxone pilot, tremendous success. We had cooperation between all of the agencies working together, and it's just amazing to see the success and the change in these people's behavior. As I've mentioned, the peer group counselors are invaluable. They speak the language and they are the bridge to allow us to be able to treat. We need public and private agencies to step up to the plate, and they have done so. It is amazing to see both public and private working together for a common goal. And ultimately, it's the well-being of our patients. So we're just going to show a brief video clip.
No, we're actually, it looks like we've got, we're just going to check this real quick. Okay. No, this is talking about some of the media around the program, not only down here, but up in Cincinnati.
Up in Cincinnati, that was an amazing opportunity. Laura asked if I would join her in Cincinnati. They were combating the same issue as our mini cities, and we had a fantastic opportunity to go up and interact with the city leaders and community leaders in Cincinnati and discuss opportunities for combating this issue. And they gave us a very warm, receptive environment and an opportunity to provide some of the tools needed to help this problem.
Yeah, I want to go back and touch on this. Houston is definitely available and willing to, even come out and speak with your communities in person. I know that it's something he shared with me he's really passionate about is and the county is really passionate about sharing this message with communities across the nation and even across the world. As we touched on earlier, we've all identified the problem. This is a problem for pretty much every single community at this point. So we're really in this era of talking solution and taking action. So thank you, Houston, and I'm sure we'll be hearing more from you during the Q&A.
Well, I look forward to it. Thank you.
So I'm going to talk a little bit about the role of residential treatment and kind of the grand scheme of not just the opioid epidemic, but the addiction epidemic across the country and across the world. Obviously, that's what we do here at Futures. We provide residential treatment, and we really have all the components that Houston mentioned in his program. I would say the biggest difference is a safe, structured, and comfortable environment. You can see in this slide here, that's our campus down here in Tequesta, Florida, which is a town in the city of Jupiter. If any of you find yourself in South Florida, I invite you to come visit and spend some time with us and really learn more about addictions and about the treatment of them. Our team is always happy to share our knowledge and experience. All of us that are here are very passionate about the work that we do to help those sick and suffering. We're also very passionate about supporting all resources for this disease and are obviously very excited and in support of Houston and the county's program. I've highlighted Futures typical client, and it's not just Futures typical client. This is really to highlight the dynamic, the dynamics of the disease, and to really point out that the disease of addiction does not discriminate. And I think you all are aware of that by now in your communities and in your businesses and maybe even in your homes, that it really touches all socioeconomic backgrounds, all races, gender, it just does not discriminate. So I have 4 profiles here of a Brittany, of a Lisa, of a Steve, and a Bob to kind of highlight those dynamics. The one thing that I'm very passionate about, obviously, is the role that I have here at Futures and the role that I've played in the South Florida community for almost 10 years now, and that's the role of community outreach. Before I came into this profession, I really didn't know much about the disease of addiction at all, and or about the industry as a whole. And I certainly did not know that a role like this existed. And basically what we do is we are a resource for the community for anything and all things addiction and mental health related. So that's at the public level, that's at the private level. People who are in this role spend their time out in the community networking and building reliable networks, for people to utilize when they come across this issue. Like I said, whether that's in your business, whether that's in your, personal life, or in your city. So one thing that I also want to highlight there is a lot of people in this role, we're meant to be problem solvers. So we're kind of we wear all hats, and you can reach out to us really for any kind of resource or even advice or verbiage on how to speak about this issue. So when to utilize someone like myself that's in this role. A lot of us, like I said, we're support and we're resources. All of us that are probably on this call are out there working in our communities to make some positive difference in some way. So it's always helpful to know someone who has connections with, with a topic that a lot of people struggle to talk about. You may not know how to talk about addiction or mental health issues. You might know someone who's struggling and you just don't have the language of what to say. So, a lot of times I'll have other professionals reach out to me and say, here's a situation I'm dealing with. What do you suggest I do? Who do you suggest I call? And it's our job to have those answers. We also connect people with like I said, resources, interventionists, in times of crisis. And then finally, we do a lot of community education. As we know, there's a lot of stigma associated with this condition. It's certainly getting better, I think, but it definitely still exists, and it's a little bit thicker in certain parts of the country. So really, our team here at Futures, we are a larger team. There are 8 of us. We're stationed all over the country. Combined, we have around 120 years of experience in this field, and we've helped over 20,000 individuals and families find help and resources for addiction and mental health disorders. And only a small portion of those come to our facility that we represent. A lot of them, we're just helping find the right place, the right resource for them. That can be anything from, a private therapist or a psychiatric facility, even setting them up with community resources like Houston's program or a community funded, substance abuse center. So, obviously feel free to reach out to any of us at any time. And then, we also have a network all over the country. And we can connect you with someone who does what we do that works for another center. Like I said, I just really want to highlight it's helpful to know someone who does what we do, because a lot of times it's a one phone call for a professional like yourself who's very busy, and it may not be that you don't care, you don't want to help. You just might not know what to do, and it's our job to know how to guide you. So I want to thank you all for listening. I'm going to turn it back over to Rebecca, and hopefully we have some questions.
Thank you so much, Laura and Houston, for that enlightening presentation. We do have a couple of questions. I am going to start with one that says, does the person that needs to be treated have to have a physical house or address? We have a homeless resource center that serves as an address for many of our homeless residents. Houston, I know you mentioned that you and your team were willing to meet people who needed assistance at a restaurant, for example. So does a homeless resource center serve the same goal as that restaurant?
Well, that's a great question. I would say that provided the homeless facility or shelter was receptive to allowing medical assisted treatment, then it would work. Where we run into a problem is where the homeless shelters demand absolute abstinence, and that doesn't always work when we're trying to deal with medical assisted treatment and therapy. So to answer that question the best to my ability, I would say there are plenty of facilities out there that support homelessness and would be able to support or facilitate us coming into their environment and treating.
Great, thank you. Next question is, What roles can a downtown organization play in combating this epidemic? And the notes behind that is much of our experience in New Haven is that we have treatment clinics that have a treatment first model, but the rest of the state of Connecticut does not. New Haven is treating many of the state's toughest cases of opioid addiction and also sees over 400 people a day who are traveling from other cities.
Well, I've actually read quite a lot about New Haven's challenge, and I applaud them for what they're doing. And it is difficult to get the state on board, but we took and conceptualized an idea at the grassroots level, and we're able to implement it to the point now where the state here is going to utilize our pilot as the roadmap or the protocol for future ongoing opioid treatment avenues. And so in New Haven, with the number of patients you're seeing, we probably don't see 400 a day, but we are seeing a lot of patients. And I would just encourage you to work with your city agencies, public and private, to include your EMS, your law enforcement, your fire rescue community, and your hospitals, as well as all of your treatment facilities, and come up with a common solution to where maybe you could collectively provide medical assisted treatment with behavioral health care.
Thank you. Next question is, how is your program funded?
Well, that question comes up frequently, and the way that we initially did this, and it can be repeated just about anywhere, if you have a EMS system or a fire rescue agency that is funded, you already have personnel that are trained to provide medications. And so if you have buy-in from your medical directors and you have hospitals willing to participate at this level in the emergency room, there's a couple ways to do that. We did not pay anybody for this position. If we had individuals that were what we refer to as light duty, they weren't able to be in a combat role of fire rescue right now, but they're still trained as paramedics, we were able to utilize them because they were assigned to headquarters for 5 days a week. And so we were able to go out and interact with the patients. We tapped into our healthcare district, which is a federally qualified health center, and those are established all over the country and in cities. And so that may be an avenue of getting providers to give medications at a much cheaper cost. And then additionally, what we looked at, and now what's starting to happen is you have local, state, and federal funding being made available through grants. And quite frequently, the language in there includes medical assisted treatment required in order to get funding. So if you look at getting support through your local, state, and federal agencies, bring everybody together, mimic our plan, or come up with one similar, and you'll see success.
Thank you. Next question is, approximately how much time should pass between the first dose of Narcan and the ER physician assessment?
Well, that depends on how much of the drug has been consumed, their tolerance. But when we give Narcan, typically it lasts for about an hour and a half to 2 hours. If the opioid is metabolized, then they typically will do fairly well and not go back into respiratory arrest or depression. But they should be seen by an ER physician within probably the first half hour of arriving in an emergency room. After a nurse has evaluated them or other practitioner, an ER physician should be interacting with that patient fairly quickly, because after all, it is an emergency. When we bring patients into the hospital after Narcan, we put them into a state of acute withdrawal. And that is a defined, billable issue for emergency rooms. Frequently, they being insurance agencies, don't like to pay for overdoses. However, when they're in a acute withdrawal, that's a different billing code. And so that would facilitate that they get continued care.
Thank you. Next question is If we would like to create a similar plan for our town or city, where do you suggest we begin?
Sounds like you may already be beginning by just participating in this conference and just having the discussion. Maybe there's already established organizations trying to work on it at the grassroots level, or some private or public funded agencies trying to work on it. The goal there would be is to try to get everybody to come together, with then the ability to lay out some goals and objectives and how you're going to get there and implement it. I'm really big on not having meetings that are just to have meetings. I'm big on having meetings that make results. So if you can get cooperation from the different agencies to come together and be goal driven, and the goals being to have success and move forward, then that would probably be the best way to go.
And didn't you suggest up in Cincinnati an organizational chart? You can kind of pull together what resources you have and kind of go from there.
I did. I just kind of, if you look at the whole flow of this, is you have a patient, you have a pre-hospital provider, you have an emergency room or hospital type setting, you have care within the hospital, and then you have discharge plans. And once they're discharged, what's the plan? Where are they going, and who's going to look after them? Do they have an opportunity to go to inpatient care or outpatient care, or can they just do detox? But you need to bring all of those together in order to assure success. And if you leave one out, then there's going to be a problem. But if you work together from the time these people enter the program, and I want to add a really important component to that, which we've now adopted, and that is prevention. So through educational components out in your community, through the schools and other agencies, through your churches, local community supporters, if you have an educational component going out there, you'll already start to reduce the number of overdoses.
Great, thank you. Next question is, are you currently working with any private treatment centers in Palm Beach County? We are having an influx of for-profit treatment centers and are trying to mitigate the negative impact on the city.
Well, we will work with whoever is willing to work with us that is certified by the state as a treatment facility, and you have to be careful with that. There are some bad players out there, and it's kind of hard to determine who is who. But by having certifications established by the state for the benefit of behavioral health counseling and drug treatment, and aligning yourself with those groups and qualified peer group counselors, you're less likely to encounter those bad players.
Okay, thank you very much. As of right now, seeing no more questions, I will say to our attendees that if you do happen to think of another question, please send those questions to me. I'll make sure they get forwarded on to Laura and Houston. We'll get you the answers for those and send them along with the link to today's recording. I would like to thank all of the attendees for joining us today. Once again, this recording will be sent to you within the next 3 to 4 business days, and I hope you have a great day. Thank you so much to Laura, Coons, and Houston Park.
Thank you.
Thank you.